6,000 unaccounted deaths. And it's the same story in each of the places the Times looked at the data. But this phenomenon is also showing up at the micro level in this incredible account from an emergency room doctor in New York City who recounts people heading to the ER for non-coronavirus reasons, turning out to have an advanced form of virus. Quote, the patient stabbed in the shoulder, whom we x-rayed because we were worried he had a collapsed lung, actually had COVID pneumonia. In patients on whom we did CT scans because they were injured in falls, we coincidentally found COVID pneumonia. Joining me now is a doctor who wrote that excellent piece, Dr. Richard Levitan, who volunteered to spend 10 days in the ER at Bellevue Hospital at the beginning of the month. Doctor, this piece really, I read a lot of medical accounts, and this one really, really compelled me. What was your experience of the sort of finding out that patients you're treating, not thinking they're COVID patients, are in fact COVID patients?
I think the most remarkable aspect of this story, Chris, is that COVID pneumonia actually does not cause subjective respiratory problems to most patients until it is very advanced. That there are many patients who have COVID pneumonia who don't realize it. Probably, I would say in the United States, thousands and thousands who have had COVID pneumonia and don't even realize it. And that the way it advances, the way it kills, is with relatively few symptoms initially, it advances to a very serious level of low oxygen. And then when people present, they are very seriously ill. So I called this in that piece in the New York Times, silent hypoxia, that it progresses slowly, and patients actually don't have a lot of subjective shortness of breath until it gets very advanced and unfortunately very serious.
And so was your conclusion, when you're seeing these patients who are in there not initially presenting as COVID patients, and again, this is speculative, but I'm curious what your sort of inference is here, that the population in New York just has a lot more of it going around than people realize, or that people are coming in and not realizing this is the thing driving their symptoms or whatever sort of distress they're feeling?
So I actually think the illness of COVID pneumonia sort of spans the gamut. There are people who come in with no complaints at all, and we just check an oxygen that's slightly low, but they came into the emergency department for falling down the stairs and they have a laceration on their head, and we end up finding that their oxygen is low, and it's because they have COVID pneumonia. But on the other end of the spectrum are the people who are dying silently at home, and all those unaccounted deaths that you mentioned. And there is this large bunch of people, obviously, presenting to emergency who become short of breath, and by the time they are symptomatic, their disease is very advanced. So we have a full spectrum of people with mild symptoms who maybe never went to the hospital for it, who have gotten over it, or people who we coincidentally find it. There's people in the middle who are there for the respiratory problems, but when we diagnose it, it's already very advanced. And then there are many, many people obviously dying at home with COVID pneumonia who never realized that that's what was going on.
That point about the kind of hockey stick nature of the disease's progression, at least in terms of its danger, I've heard from other doctors treating it. I mean, that they have a patient in front of them who seems fine, and their oxygen just doesn't make any sense. Like what's showing up in the readings is someone who should be flat on their back, and there's a mismatch between how they're presenting and what reading they're getting about their oxygen level.
It is like nothing anybody has ever seen. The only comparison I could make is these folks have blood gases in terms of their oxygen, their carbon dioxide, their breathing, that matches what is happening physiologically on the top of Mount Everest. These people have oxygen levels that are not compatible with life, but the way they got there, I believe, is slowly and insidiously. If I were to drop your oxygen from 100%, or let's say 95%, where most of us are, and then we brought you to 50%, everybody who has that sudden drop would be unconscious or having a seizure. These people are on their cell phones, but they are dangerously close to the limits of what humans can tolerate. And then they deteriorate abruptly. Unfortunately, the way we normally detect shortness of breath, the way we normally feel short of breath, is when our carbon dioxide rises, or we get some, feedback from our lungs of pain or something else. These people don't get that. Their carbon dioxide is very low, actually. So it is low oxygen with very low carbon dioxide. They're breathing, they're compensating, and they do that silently until it gets to a very advanced stage, and then they show up with these numbers, and we look at it, and we just can't get our head around it. But it matches physiologically what happens at extreme altitude, at 29,000 feet on Everest. It's insane how low their oxygens are.
Dr. Richard Levitan, it was a really fascinating piece and great talking to you tonight. So much. Thank you for your work and for your time tonight.
Can I just say, Chris, that, the heroes in this story are the workers in New York, the emergency docs, the nurses, the respiratory therapists who have learned a lot about this disease. I think when we look back on this, as people talked about the RAF, about, so much was owed to so few by so many, I think that America will look back and realize that we learned a lot from New York City. And I just was there for 10 days, but the shout out goes to those folks.
Thank you. I really appreciate you saying that, Doctor. Be well.
Thank you.